So I am the first speaker, and I'm going to talk a little bit about characterizing non-infectious posterior uveitis. Thanks. Nope. There we go. So here are my disclosures, and they are not specifically related to this talk. So the non-infectious posterior uveitis disease consists of a variety of diseases listed here on the left that have been previously described as white dot syndromes. The problem with this is that the majority of these diseases are really not white. The chorioretinal lesions are a variety of different colors with a variety of different pigmentation. And they're not all dots or spots either, serpiginous being kind of the obvious one, that the lesions are windy and snake-like or almost amoeboid. And so trying to characterize these diseases or describe what phenotypically you see is something that we've been working on for the better part of almost 2 decades now. And so I'm going to kind of tell you a little bit about where we sort of started, and then the other people are going to talk about more things having to do with imaging and how you could characterize these diseases and hopefully distinguish one between the other. So some of this work started with something called the Standardization of Uveitis Nomenclature, which is a group of uveitis specialists that were tasked at trying to define different types of common uveitic syndromes. So we have about 6 or 7 of these so-called white spot syndromes that we now call non-infectious posterior uveitis because it's as good as a descriptor or better descriptor than white spot syndrome ever was. This project began about 17 years ago, and the idea was to build consensus so that people understood that we were sort of all describing a similar disease, or at least the more typical
Good morning, everybody,
so
and
that we could,
thanks.
Do a better job of defining outcomes, how to monitor the diseases, how to incorporate this into research. So this had 5 different phases, which are listed below, and the publications that came out of this were about 28 publications that were published in the American Journal of Ophthalmology in 2021. So with posterior uveitis, having imaging can be incredibly helpful. It allows you to sort of see things in real time, think about the disease. You may not always notice every nuance of a disease when you're looking in on your clinical exam, but having a fundus photograph or that fluorescein may add to your understanding of really what you're looking at, whether it's active or inactive, and help you decide what you need to do with treatment. So with SUN, we collected images, although the main goal was to actually develop descriptors or sort of common language to describe what the lesion that you're looking at looked like, how much pigment was there, what location it was in the retina, the choroid, or a bit of both. And we used this. We used the images to sort of corroborate this, but even if the images were not available because people were kind of using these agreed upon language, you could still enter cases into a database for subsequent data analysis so that we could reach consensus on these classifications of these diseases. We were very kind of particular about what images you had, so some of the other people that are going to speak are going to give you an idea of the advantages of having a complete set of images, but in this case, because these were collected after the fact, you didn't always have the images. But what we tried to do was say, if you've got chorioretinal lesions, please give us a fundus photograph to show that, or a fluorescein, or a fundus autofluorescence. If you have a case that you believe is retinal vasculitis, please show us your fluorescein angiogram. and so on. Again, because we were dealing with largely clinical data, even if we didn't have all the images, we would have sort of the gradings of those images. So what the clinician thought they saw in the images. And we presumed if the image was not available, that it wasn't necessary to make the diagnosis. So in other words, perhaps you didn't need the OCT to diagnose retinal vasculitis. You might have only used the OCT to decide whether or not there was macular edema there, but you didn't necessarily have to upload that in the database, because the database represented 7,000 cases, and this was people all over the world volunteering their time to enter this information. So we tried to make it as user-friendly as possible. And we had historical data in these cases as well. The tough part was the disease wasn't always necessarily active when you collected the case, okay? And so you'll hear from others like Dr. Ganga Putra that sort of these multimodal imaging helps us determine active versus inactive, which is a layer that goes beyond what we were doing with the SUN project. We did a series of case selections. So for posterior uveitis, this was 250 cases of each of the diseases. And you went through and you reviewed this in committee with a group of about 10 of your colleagues. And then there was a formal Delphi technique or a nominal technique where everybody got to say sort of their 2 cents of whether or not they agreed this was a case or not. And if there was a consensus of a supermajority, which is more than 75% of the people said, yes, in fact, I believe that this is a case of birdshot, then that was sort of a case, so that was passed. If it was less, then there was adjudication, more discussion, and if possible, they tried to come to a supermajority agreement of what a case was. If the case was sort of there was no supermajority, then that case was essentially thrown out of the database. So the database was comparing cases where the majority of uveitis specialists said this is in fact birdshot or this is in fact multifocal choroiditis. And then they were compared disease to disease, okay? So machine learning, now you have a bunch of cases of the 6 or 7 different non-infectious posterior uveitis. You also had infectious posterior uveitis that went into the database. And then what we did was compare them disease to disease to generate a list. The computer generated a list of these sort of descriptors. Which factors are really, really necessary for somebody to say, aha, that's a case of birdshot and not a case of PIC, okay? There were no normals. Okay, so just the disease entities here. And so, but you don't really need normals if really what you're trying to do is you're trying to say these are the specific factors or features that you see in a case where the experts agree that that's a true case, okay? So you don't have the normals, you don't have the negative set, okay? And that's why you can get away with this type of looking at these different diseases. All right, so there were a total, so it started at about 7,000 cases. They narrowed to about over 4,000 cases. That included all different anatomic locations of uveitis and non-infectious and infectious. When you looked at just the posterior uveitis, it was 1,068 cases. So 85% of that was used as a training set. That's where you're teaching the computer what's important. And then you've got the remaining 15%, which you hold aside, and then you use those to try to validate. So in order to prove, did the computer get it right, or did the computer just completely mess this up? Okay? We use something called evidence for because you've got a small number of cases with a lot of different variables. So sometimes what you ended up doing is combining variables. So in other words, for PIC, the computer thought it's important for these lesions to be small, okay, under 100 microns. And it's important for the majority of them to be in the macula. So they combined or engineered these combined features so that you didn't have 1,500 some odd variables that you were trying to cross-reference, which makes it very hard to do with kind of a standard machine learning capability. We're getting to the point now where we can, we can look at terabytes and terabytes of stuff. If anybody's familiar with the foundational stuff that they use the fundus photography, and they say, is this person a man or a woman based on the retina? That's terabytes and terabytes of data. That's not this, because uveitis is a rare disease, so you kind of get what you get, okay? When we looked at accuracy, the accuracy for these cases were quite good. If you see, we looked at 9 diseases, so it was the 6 non-infectious and 3 additional infectious, and the accuracy was 98%, and you see the confidence intervals there that are still fairly tight. So good, strong result. All right, so now what are we doing? Well, now we're moving into move, okay? And so this is the multimodal thing. So now we've got kind of how we want to talk about these diseases. Now everybody's collecting these prospectively acquired data sets, active disease, inactive disease, multiple photographs. And this potentially allows us to kind of dive deep down into what are you seeing on those images that distinguish the two. Provides for a better data set, a longer lasting data set, gives you ideas on how to monitor the disease, what is active, what is inactive, and potential for extra research. So in summary, the start of this was to define the typical case, and to define the verbiage in order to describe the cases. And this worked very well. It's got good performance both clinically and translationally. But this now becomes that scaffold about what you're going to hear about next, which is the multimodal imaging that's really kind of the crux of dealing with these diseases. And I think the next person, we're going to do Sapna, yep? Okay. Thank you.